This is Dr. Jeremy Hampton. Welcome to part 1 of your lecture on afib. I thought it'd be a good idea to start off with a refresher on normal cardiac conduction, because knowing how the heart does its thing electrically is really going to help you understand arrhythmias like afib better. And then after normal conduction, I'll talk about the cardiac action potential and the basic components of an EKG. Since you can't start a lecture without a few definitions, here's a few to get us started. First, automaticity. This is the ability for the cell to spontaneously initiate an impulse, and it's something that happens in the pacemaker cells of the heart. So this pacemaker cell looks like he's about to spontaneously fire. Excitability is the shift of ions across the cell membrane, and it indicates how well the cells can respond to an electrical stimulus. So here, this pacemaker cell is getting some sodium shifted inside of him, and some potassium is flowing out. And it looks like he's responding pretty well to the electrical stimulus. Conductivity is the ability of a cell to transmit an electrical impulse to another cell. So this first pacemaker cell takes out his impulse gun, and he shoots or transmits an impulse to the cell next to him. Let's call him Engelbert. And finally, contractility describes how well the cell contracts after receiving stimulus. So here, Engelbert just received the stimulus from his neighbor, and now he's contracting away. So there's a stimulus, and he's contracting. Now let's move on to how an impulse is conducted through the heart. Now the action is all going to start up here at the SA node. It's up in the top right corner of the atrium. This is the main pacemaker in the heart, and it's responsible for generating anywhere from 60 to 100 impulses per minute. It's got the highest degree of automaticity in the heart, so even though there are other latent pacemakers in the cardiac tissue, they typically don't have enough juice to overcome the SA node, which means they can't typically trigger conduction. This means the SA node is the primary pacemaker in the heart. Now after the SA generates an impulse, it splits out to the left through Bachmann's bundle and reaches into the left atrium right here. This happens so fast that both atria are going to contract at the same time. Now the rest of the impulse moves from the SA node down to the rev limiter of the heart, the AV node. The AV node is situated at the bottom of the right atrium, and its main job is to slow down the impulses that reach it by about 0.04 seconds so the ventricles don't fire too quickly. This lets the ventricles fill up as much as possible while the atria are contracting, which helps to maximize cardiac output. AV node doesn't have any pacemaker cells of its own, but it's surrounded by junctional tissue, and that can fire anywhere from 40 to 60 times per minute. After leaving the AV node, the impulse moves down through the bundle of His on a ride through the ventricles. The bundle of His gets divided into bundle branches, with one on the right and two on the left. Now the reason there's more on the left side of the heart is because the left ventricle is bigger and it's thicker than the right, since it's responsible for systemic perfusion. It needs the power from the extra bundle to make sure the ventricles beat at the same time. The impulse moves from the bundles into the Purkinje fibers, and this takes it into the endocardium and deep into the myocardial tissue. These fibers have pacemaker cells too, and they can generate about 20 to 40 impulses per minute, but they usually don't fire unless there's a bundle branch block or the SA and AV nodes aren't firing correctly. So when you put everything together, you get an excitation-contraction coupling process that's responsible for getting the heart to beat. This beating cycle is basically a cyclical process of depolarization and repolarization. The depolarization phase is the action phase, so it triggers the beat. And repolarization is the resting state. So while cells are in the repolarization phase, they can't do anything because they're refractory. Now let's move on to the action potential. The action potential is something you probably don't think of very often, but when you understand how it works, it's amazing how much easier it is to figure out the mechanism of drugs and how they'll help or hurt you. Basically, all these impulses and contractions are caused by shifting intracellular and extracellular electrical gradients, and it's all made possible by sodium, potassium, and calcium. So let's see how this process works. The action potential consists of 5 phases, 0 through 4. I have no idea why they start with 0 and not with 1, but we'll just work with what we have here. So phase 0 is where the action is going to start. It's marked by fast sodium channels opening, and sodium floods into the intracellular space. So here, this jet is sodium, and it's flying at Mach 1 into the hangar, which represents the intracellular space. That intracellular space is going to become positive, and is quickly going to reach the depolarization threshold of plus 20, at which point phase 1 is going to begin. During phase 1, the sodium channels close, the sodium jet crashes into the hangar door, and we end up getting ventricular depolarization. After this, phase 2 immediately begins, and we see the slow calcium channels open up, and they're represented by this little old lady wheeling her calcium wheelchair into the intracellular space of the hangar. Potassium, which is obviously a young punk teenager who doesn't want to hang out with old ladies in calcium wheelchairs, starts to filter out of the cell and into the extracellular space. This is the plateau phase, and although old lady calcium is slow, she gives the ventricles that added oomph for contraction. Phase 3 is marked by the closing of the slow calcium channels and the beginning of repolarization. So even though the calcium has stopped coming in, the young punk teenager potassium is still leaving the cell, and he's trying to create an increasingly negative intracellular gradient. Finally, we get to phase 4. This is the point at which the gradual depolarization of the cell begins, and the slow sodium biplanes start to enter the cell. Potassium decides he's going to go ahead and play nice, and he agrees to slow down his rate of efflux to help make the cell a more positive place. This continues for a short time until the threshold potential of the cell is reached, and phase 0 begins again. So the steeper the slope of phase 4 is, the quicker depolarization is going to occur. Or another way to put it is, the slope of phase 4 determines the automaticity of the cell. Since the action potential describes how the flow of ions gets the heart to beat, let's take a look at what it looks like electrically as an ECG. It's important to note that the ECG waveform only describes the electrical activity of the heart and has nothing to do with the mechanical pumping. So take for example a patient in cardiac arrest who presents in pulseless electrical activity, or PEA. So even though the patient's heart isn't beating, you're still going to see an ECG waveform on the monitor that could look like normal sinus rhythm. The heart's still transmitting electrical impulses, and they're being detected by the ECG, but there's no cardiac movement there. So here's a basic ECG complex. In the most basic sense, it has 5 primary waves: the P wave, the Q, R, S, and T. The P wave represents atrial depolarization, and then the PR interval tracks the impulse from the atria through the AV node, down the bundle of His, and then through the bundle branches. Changes to your PR interval are going to indicate some kind of altered impulse formation, or potentially a conduction delay like you'd see in AV block. A PR interval shorter than 120 milliseconds means the impulse originated somewhere other than the SA node, and is associated with junctional arrhythmias and pre-excitation syndromes. A prolonged PR interval greater than 200 milliseconds could indicate a conduction delay through the atria or the AV junction, and it might be caused by digoxin toxicity or heart block. The QRS complex represents depolarization of the ventricles. As soon as they depolarize, they contract and inject blood, creating a pulse. So when you say you have a heart rate of 80 beats per minute, that means that you would count 80 R waves, or 80 QRS complexes per minute on your ECG. The ST segment marks the end of ventricular conduction and the beginning of the rest phase, or ventricular repolarization. If you have a change to the ST segment, it could indicate myocardial ischemia. So with a myocardial infarction or a STEMI, you'll see an elevation of your ST waves. So it's going to indicate myocardial ischemia. The T wave marks ventricular repolarization. And if you see tall, peaked, or tended T waves, it's likely going to represent either myocardial injury or more likely hyperkalemia. So if you see a patient and the resident tells you that they have peaked T waves, you should right away send off a BMP and start thinking about what you're going to do to treat the hyperkalemia that they're most likely going to have. And finally, the QT interval measures ventricular depolarization and repolarization. Or another way, it describes the entire ventricular process. This means the faster the heart rate is, the shorter the QT interval is going to be. A normal QT interval is going to range from 336 to 440 milliseconds, and it shouldn't be any greater than half of the distance between consecutive R waves. A long QT interval tells you that the ventricular refractory period is longer, and a refractory period that's too long is going to increase the risk of developing torsades de pointe. So remember that medications can prolong the QT interval, so you should always be aware of what patients are receiving, especially if they already have a long QT interval. A great resource to look for information on drugs associated with QT prolongation is azcert.org. So this brings us to the end of part 1. In part 2, we're going to go over abnormal conduction.